So thank you for inviting me to participate in this important and fantastic meeting. I'm going to talk about the perspective of imaging phenotype for Li-Fraumeni syndrome. So the outline of this presentation will be the optimization of imaging protocols personalized on data evidence based on a retrospective study that we conducted here at SickKids. And based on that, try to visualize and identify the diagnostic accuracy of whole body MRI. And I think it will be very important to compare with results of other studies that were discussed this morning. So the impact of cancer in Li-Fraumeni syndrome is huge. Everybody knows that 70 to 83% of patients with Li-Fraumeni criteria can have cancer associated with mutations of TP53. And affected patients they have 83 to 85% of a higher risk of developing multiple types of cancer during their lifetime. So everybody knows that there are genetic events that are associated with this, and they may really be related to a phenotype, and imaging is one of the ways to try to evaluate this phenotype. However, there is a tremendous phenotypic heterogeneity, as we're going to see in this presentation, and I'm going to walk through the different imaging aspects of this heterogeneity. So these are the students who participated in this retrospective study. It was an 18-year review, I think, through the data of SickKids, and is complementary to the talks of Anita and Marie-Louise. And we tried to really see what was the right imaging timing for surveillance for the right patients according to their genetics and also other exposures. So we evaluated the interval of times for the development of cancer in all patients of our cohort, and tried to evaluate the accuracy, the false positives and false negatives of whole body MRI specifically, and also these patients underwent other types of imaging modalities, and tried to see what was the accuracy of whole body MRI. So as you can see here, this data was evaluated between 1999 and 2017. We evaluated a total of 43 patients, and we had imaging data for 40 of these patients. We evaluated 1,430 imaging studies, and we had 40, out of these 40 patients, we found 39 tumors. 23 patients were affected, and 17 patients were unaffected. However, as you can see here, there was a tremendous heterogeneity in terms of gDNA and protein, so we couldn't find any patterns. Just showing this is a single-center study. It's clearly needed a multicentric study to be able to have to draw relevant data in terms of genetics. And this is what I'm just showing. I think the division in 70% versus 30% of patients. And in terms of the interval of time between time points for development of primary cancer, we could see that the average time was 1,625 days, or 4.5 years for development of the patients that had multiple tumors. So this would be the interval of time for the development of cancer, I think, from one tumor to the other tumor in patients who had more than one tumor. So in this category that I think 30% of patients had multiple tumors, they either had synchronous tumors, it means both tumors were found at the same time, and 2 patients had double synchronous tumors. They presented 2 times synchronous tumors, and other patients had 1 tumor after the other. And just, I think, in terms of recurrent disease, so this, I think, how much time it took for patients to develop recurrent disease. On average, it took more than approximately 1.5 years, 347 days for the development of recurrent disease. And we just, I think, have, out of these 33% of patients who were affected, I think we had 10 recurrences representing 10 tumors. So in terms of genetics of these categories of patients who developed, I think, recurrent disease, 10 patients had 1 recurrence and 3 patients had multiple recurrences. Also, the genetics were very heterogeneous. And this is another point. If the patients only had one episode of recurrence, the interval of time between, I think, the identification of these tumors by imaging was 562 days, or 1 year and a half. And those patients who presented multiple recurrences was much lower, like 4 months, likely representing higher aggressiveness of tumors. Out of these 39 tumors that were identified in our population, we had different categories of tumors: 9 adrenocortical carcinomas, 5 osteosarcomas, 5 rhabdomyosarcomas, 3 soft tissue sarcomas, 1 chondrosarcoma, 10 brain tumors, 1 neuroblastoma, 3 hematologic malignancies, 1 adenocarcinoma of nasopharynx, and 1 thyroid cancer. In terms of false positives and false negatives, there were larger studies, especially the study conducted in Europe that was multicentric. This was a single-center study. Considering only malignant lesions, we found that out of 135 whole-body MRIs, 12 false negative results, representing approximately 9% of the cases, and 12 false positive results, representing 7% of the cases. These were, I think, the criteria for identifying one case as positive is either if the tumor was proved to be malignant by biopsy, or if there was an equivocal lesion on imaging that after biopsy was considered malignant. A negative case, if the patient was followed and there was no growth in the tumor or in the signal, that abnormal signal that was identified by the MRI, or there was a typical benign lesion identified by imaging. Indeterminate lesions or equivocal lesions were considered either false negatives, if we thought initially that the signal was abnormal, but following up it didn't change, or it was false negative. I think it grew over time and it was diagnosed as positive further on. In terms of chest studies, we had 135 chest parts of the whole body MRIs, 135 abdominal parts of the whole body MRI, and 158 skeletal lesions in general. So this is the problem of evaluating the accuracy of whole body MRI when we have a relatively small number of cases. As everyone knows, sensitivity is the true positives divided by true positives plus false negatives. Because we didn't have many true positives, I think the sensitivity of whole body MRI for assessment of skeletal lesions were very low, 57%, chest 50%, and abdomen 67%. But I just would like to emphasize that this is related to the low sample size. These are the 12 studies that I think we evaluated that false negative results were obtained. I'm going to show you some examples. This example is a 7-year-old patient with known Li-Fraumeni syndrome, had previous adrenocortical carcinoma. And on this MRI here, it was not detected due to these vertical high signal inversion recovery images that there was a tumor here. Then I think the patient started with symptoms, and a dedicated MRI was repeated 102 days, more than 3 months after. And there was a tumor here that was diagnosed as a classic osteosarcoma in the proximal aspect of the left fibula. So this was, I think there was an interval of 3 months. And just 1 month after this diagnosis, the patient started with pain in the contralateral lower extremity and was diagnosed another osteosarcoma. This was a periosteal osteosarcoma. So this is a case that whole body MRI for this follow-up could have been very valuable, because we had to do 2 different dedicated MRIs of different parts of the body. And with a whole body MRI, most likely we would be able to see the second lesion that we couldn't see 3 months before. This is another case that Marie-Louise showed a similar image. This is a patient, was a 19-year-old patient at the cancer diagnosis, also with Li-Fraumeni syndrome. And on this case here, circulating free tumor DNA was associated with the imaging. And as you can see here, with the growth of the tumor, there was at least doubling of the plasma levels of circulating DNA. This is just I think, between the MRI, I think this signal intensity abnormality was not diagnosed, and 1 year and a half after it was diagnosed here, the patient was lost for follow-up, and when she came back, I think the tumor was huge and there was metastatic disease. But you can see here that the circulating DNA also showed an elevation. This is just a preliminary results, I think, of this study. Tanya and Titi Porn were students who were conducting that. And this technique aims at providing a unique marker that can differentiate tumor from genomic DNA. And these concentrations of circulating DNA in the plasma potentially can be associated with imaging to provide more accurate information. This was the technique that was used, the quantification of positive droplet count and using fluorescent signal. However, this technique was not very specific, and if the patient had any burden of the tumor, like chemotherapy, the levels could go up, causing like false positives. So there are techniques in the future that could be used, like using, for example, transcripts of differentially methylated regions in TP53 mutations that could be more sensitive and specific. I'm going to show you another case that there was association between circulating free DNA and imaging. This is an 18-month-old girl at cancer diagnosis. She had a left adrenal adenocortical carcinoma and responded very well to chemotherapy, and you can see that there was a decrease in the plasma circulating DNA levels, and there was just residual disease that I think there was even, some question if this was a lesion, but with the ultrasound showed that it was just represented a retroperitoneal fat. So this is another example that potential value in the future of association of laboratory and imaging findings for surveillance. So now these are the cases of that we found false positive lesions on imaging, not only whole body MRI, but other imaging modalities. And these are some examples. I think this is the genotype of the patient. This is the phenotype. In this patient here, we found this increased signal intensity in the right pubic ramus, and it was followed, as you can see here, monthly. And finally, it was decided to do a biopsy, and it was an aggressive procedure. It was normal tissue. It was just a variation of an island of hematopoietic bone marrow. This is another case that I think everyone who works with whole body MRI, we see that very frequently, we see some focal increased signal intensity, especially on inversion recovery imaging, and we follow and they don't change. Sometimes they disappear, and these were also false positive cases. So what are the key points of this presentation? So probably the aim now is to optimize the timing of imaging surveillance, right time of imaging surveillance for the right patients based on their genetics and other exposures. And we had a very small sample size to draw diagnostic accuracy for our whole body MRI. As you can mention, if I think the rate of true positives is very low, the sensitivity gets low. However, we can notice that in most of the cases of when we had a new primary tumor, which represented 70% of our cases, the time for visualization of a tumor was 4.5 years, and our annual surveillance was very good to identify tumors. For recurrent disease, I think considering all different types, single recurring disease versus multiple, it was almost 1 year, close to 1 year, so also we would be okay, I think, surveilling patients every year. However, I think 7% of these 30% is a very small rate of patients who have very aggressive disease and have multiple recurring diseases. Then the tumors really are seen in these interval tumors are seen on imaging in 4 months. So in this case, I think specifically we need to identify genetically who are these patients who need surveillance every 3 months. So this is the point that we are in our investigation at the moment, and we want to share these, I think, questions, I think, for everyone. In terms of skeletal lesions, I think this is another point that was discussed about the false positive rate. When you have associated soft tissue changes to the bone marrow changes, this facilitates the diagnosis of being a true positive instead of a false positive. And there are multiple pitfalls for false positive results. We just showed some of them that should be recognized. I would like to thank for all the group who has participated in this exciting research, and thank you very much for this opportunity.
Great. So again, thank you, Andrea. Another time for a question or two. Yes.
Who would fit the profile for needing more sooner MRIs, like the 3-month? Like, is it just based on what you see, or is it based on previous cancers, or?
At the moment, most of our patients are followed on an annual basis. So only patients who really have symptoms are the ones that are really followed within a shorter period of time. Our dream is that in the future, there's some type of combined tool that is able to indicate which are the patients who need more frequent whole body MRIs. And this is the point that we think that we need to associate with other tools to be able to make the stronger, not only imaging, but possibly laboratory findings as well.